I'm coming to you kind of in between jobs. So we're going to make this fast, but hopefully effective. I'm going to go over the test that y'all took. I know that there were some problems. And so hopefully this can clear any up if you have any. And I will try not to go off on a tangent. And this will give you the answers if you don't already know them. This is for chapter 7, 9 through 10, and 13. Please forgive me if you hear little bear playing in the background because she's got to be by me. But so number one, a trauma patient will feel fear and embarrassment on the scene, and that's just natural because they don't know you. They've just been in a wreck. They're probably embarrassed that they've been in a wreck, or just upset that it happened. And if it's a significant wreck, what are we gonna do? We're gonna get them trauma naked, and so nobody likes being naked in front of somebody that they don't know. Well, I mean, at least most people. So they are gonna feel fear and embarrassment. So that's something that you really need to remember and try to keep modesty. You can put a sheet over them, um, but you do need to make sure that they're trauma naked so that you can assess every single part of them. Don't forget to check their back. Don't forget to check their back. Don't forget to check their back. Anyways, so, and if you see me keep looking over this way, it's because I have my computer right there. But, so number two is about hearing. Hearing typically reaches maturity around 3 to 4 years of age, and that's because we know that babies can hear when they're smaller, but for their brain to process exactly what they're hearing and be able to associate it with that, of course, like if you snap your fingers, the baby's gonna look. If you clap, we all know babies love that. But they really don't start to properly associate that hearing with what it is until around 36 to 48 months. So one of the highest is number three. One of the highest priorities for a rescuer is to assure that the airway stays clear, and to do that, we need suction. You don't want to be sticking your fingers in someone's mouth. And I know that bringing the suction is kind of hard because on just a normal call, we don't grab the bag, grab the monitor, and grab the suction. That's just not what we do. But always on a respiratory arrest or cardiac arrest or maybe a breathing problems that they say that they have CHF, if you get good patient information, you can kind of process that like, oh, I need to bring that suction in. No matter what, if you're on a cardiac arrest, bring that suction in because like I told you guys during CPR, inevitably somebody is going to have a fluid buildup. You won't be able to see to stick a king airway in or to intubate, and there might be a green bean or two. I've got PTSD from green beans being flung out during CPR, but suction is a very important tool to use. So number 4 is about the pupil dilating or constricting. The only one out of that list, which was shock, anxiety, cocaine, and organophosphates, the only one that causes pupil constriction is organophosphate poisoning. And remember, with the organophosphate poisoning, sludgeum, salivation, lacrimation, urination, defecation, emesis, and and meiosis is a constriction of those pupils. If someone's in shock, their pupils get really big. If someone is anxious, their pupils get really big. Same with cocaine use. But organophosphates, they are the ones that cause vasoconstriction. Pupil constriction, not vasoconstriction. So number 5 is maintaining C-spine control and perform the primary assessment as the patient is found. So I'm just going to read what this says real quick. The primary assessment can be completed in the position with the exception of the anterior chest. If you find a patient in the prone position, you should complete as much as you can of the primary and then quickly perform a brief secondary such as the arms and legs, to make sure you cause no further harm. And then roll the patient and to pick up the primary where you left off. So if they're prone, you can see what's happening on the back, which is great because a lot of people miss the back when somebody is laying supine. So you can still you feel down those arms, feel down those legs. You can walk your hands down the spine. You can check the hips if they're in their prone position. But then make sure to maintain C-spine and roll them over. Now, I'm going to get off on just a little tangent real quick. If you have got more than one person there and you're holding C-spine, and you got a lot going on, but you've got that person that can help you, something to think about, and I will show you guys this Saturday, is hold that patient's leg between your knees, and you can do the first half of the body, the top half of the body, and you can assess that while your partner is doing other things. Like the person at the head is a great person to assess airway. They can look to see that there is equal rise and fall of the chest, no flail segments, so you can work together on that. Don't think that you have to do it all by yourself, but the key is good communication. So make sure that you communicate with your partner like, hey, airway's open, pupils equal round and reactive, nose is clear, eyes are clear, I can see equal rise and fall of the chest. If you're up there, you can even listen to lung sounds, while that other person can be palpating the stomach, making sure that the hips are okay, going down each leg, checking PMS. Just work together. We're all a big team, we're all a big family, just remember that. So that was number 5. Number 6 is you would select a modified secondary assessment, which we know is a focused exam, when the patient appears to be stable and there's no significant mechanism of injury. All the other choices provided should receive a rapid trauma assessment. So there was the general impression is poor and there's significant mechanism. The general impression is stable, but there is a significant mechanism. Your general impression is poor, but there is no significant mechanism. But the correct answer was your general impression is stable and there is no significant mechanism. If there is any question, any mechanism that's significant, automatically that calls for a rapid trauma. So number 7, patients with an unstable fractured pelvis will need immediate care and possible blood replacement. Remember, a broken pelvis or broken femur, that could be 1,500 cc's of blood loss. That's a lot of blood loss, and that could send somebody into shock. So it's important to notify the ED so that they can prepare for a high priority patient. And I will teach you, if you don't already know, how to do a sheet around the pelvis that's unstable. So it can also help with that blood loss, but it keeps that patient more comfortable, it keeps it stable, and it's just easier for everybody all around. We'll do that Saturday. Number 8 is an infant turning his head is known as the rooting reflex. So option B was also known as the sucking reflex, which is a response by an infant when its cheek is touched. Let me go back. Sorry. So the correct answer is throwing the arms wide and spreading the fingers when startled, like this. That is the rooting reflex. Option C, an infant turning his head in response to food. And option D is referred to the palmar grasp reflex. That did not make sense. Okay. So the answer is answer A. And their explanation is an infant turning his head is known as the rooting reflex. questions on that, please let me know. So, number 9, hypertension can cause a faster than expected capillary refill time. Because we know that hypothermia, cigarette smoking, and circulatory disease can cause delayed cap refill. Because hypothermia, things aren't moving like they should, blood's slower, everything's shunting to the core in hypothermia. Remember, just to try to keep those organs, the head, the brain, and the heart going, so the fingers and stuff will be delayed reflex. And cigarette smoking, that's because it constricts those vessels and it discolorizes their fingers, so you can't really see as well. And circulatory disease, self-explanatory, they don't have good circulation, so they're going to have delayed cap refill. So the increased cap refill will be on hypertension. Number 10. So to decide the ideal liter flow for a non-rebreather mask, you can estimate the oxygen demand by assessing the O2 reservoir capacity use. You should increase the liter flow if you find the reservoir bag deflating more than a third. So definitely know 10 to 15 liters per minute is what a non-rebreather should be, and those are for people who really are needing oxygen, or their respiratory rate is too fast, or too slow. But if it's way too slow, you're going to breathe for them. But if you don't see that bag full, it should stay full about the whole time. Then you need to adjust accordingly. So, number 11, getting an effective face shield can be one of the most difficult problems with ventilating a patient. I know I went over this with every single one of you. One rescuer should focus on compressing the BVM, and the other must make adjustments to assure that there's an airtight face seal. Let's say it's a perfect world and you have two people that can have one person. Like I said, that CE, you could do a double CE hold on that mask, but we want to remember moans, mask seal, obesity, age, no teeth, stiff neck. When it comes to ventilating, so one person focus on squeezing, the other focus on maintaining a good mask seal. Number 12, on your first overview of the patient, you take in many pieces of information that help you decide if the patient is stable versus unstable. So that's your first general impression. Sometimes there's an illness or injury that is very obvious to assist you with decisions, such as a GI bleed. If none of you have smelled a GI bleed, you will never forget it. Not a very pleasant smell, but and you can tell with a GI bleed, obviously, if they're vomiting up blood and it's dark, that's an upper GI bleed. If they have dark tarry stools, that's a lower GI bleed. If they're vomiting up blood and it's bright red, that's probably esophageal varices. Or it's some kind of irritation in there. If it's not a lot, it's probably irritation. The same as if their stool has some bright red blood, it's probably hemorrhoids or some kind of vascular injury. But dark red is no good, and it will smell horrible. And like when they vomit up the dark red, it looks kind of like coffee grounds. And then in the stool, it will be dark and tarry. So anisauria is a normal condition where the pupils differ in size greater than 2 millimeters. So an important thing to ask is if there's somebody around, or even if that patient, are your pupils normally different? Because what are we suspecting if we see them different and that is not normal for them? Head injury. Sure, y'all knew that, but I'm just reminding you. And one day, I promise, promise I'll stop saying but not today. Number 14, the resulting narrowing of the lower airways is wheezing. And remember, that's like a you'll hear it in the lungs, the sound. So the other choices were gurgling, snoring, and stridor. Those are all upper airway problems. The only lower option was the wheezing. And I apologize if it seems like I'm yelling. I'm just trying to talk over that one too. Anyway, so number 15. The stethoscope earpieces need to be positioned slightly anterior into the ear canal, and the diaphragm should be held firmly against the surface. The bell should be placed lightly against the surface. So the bell we usually use for pediatrics, and that should be lighter because you don't need to press as hard. And you'll notice that the bell like turns in. I don't have my stethoscope in here. Or I would, sorry, I was checking. Or I would totally show you, but the bell is usually not flat, and that is a good reminder that you don't need to hold it flush against the skin. But the other part, the diaphragm, that's a part with the thing that you tap that makes your ears hurt. That should be held, well, that's actually the diaphragm, but that should be held directly, firmly against the points that you're listening to. If you want to listen to make sure they've got good blood flow, and it's called Bruits, and there is nothing we can do if you hear like a whoosh, whoosh over rocks, and it's right there in their jugular. This is just random stuff that I learned, but that usually means they have really high cholesterol, so sometimes I just like to listen to it just because I can. Number 16. I'm sorry, I know I said that this would be quick, but I'm trying. So the best way to measure the OPA, I know that all of you know this because you have showed me and you've done excellent, is from the corner of the mouth to the tip of the earlobe. I'm not going in anymore because I know you all got that right. Everyone got that right on the test. I'm hoping. I haven't seen test results yet. Robin has, so. A jaw thrust maneuver. It's valuable for opening and maintaining. Oh, come here. Sorry, I have to kiss Boo Boo real quick. Okay. She got Cheetos. Anyways, so the jaw thrust maneuver is valuable for opening and maintaining a trauma patient's airway when tipping the head back is undesirable. It alone is not as useful as the other populations. Last sentence means, but jaw thrust for trauma, head tilt chin lift for medical, you know that too. So what indicates adequate circulation of the capillary refill? See that? That's my capillary refill, but and that's pinkish red. I can't, oh, it's up here. Can't really see that well either, but pinkish red. And that indicates that there is adequate circulation. So it is often said, this is number 19. It's often said that if you lose the airway, you lose the patient. Airway and breathing support will almost always take over priority over other basic support skills. Just remember that, airway. That's why I know that there's like a modified CABC, but airway, A, number one. Make sure that airway is patent and good. Rescuers must focus on keeping the patient's airway patent and assist with ventilations as needed. The only obvious exception would be discovering serious arterial bleeding during your scene size up, and then what do? Hold direct pressure. Elevate, tourniquet if needed. We'll get into that too. Okay, so number 20. Infants will frequently present pink and warm. This is referred to as a healthy look. So descriptions of pale red and cool moist are indications of a physiological problem. So the answer was D, Meredith. 6-month-old with warm pink skin. Welcome to my kitchen, by the way. Okay, the 21 is D. The term constrict describes the action of a pupil becoming smaller when exposed to a bright light. So I have this little ring light thing to try to make me look more alive. But so you can see my pupils up here, but then when I get closer, you can see that they're a lot smaller than they should be. And as I move farther back, then they open up. Number 22, the answer is C. There are absent lung sounds during auscultation. The lack of lung sounds during auscultation, which we know is listening with the stethoscope, is an indication of poor ventilations, or no ventilations. But it suggests that air is not entering the chest. The other, the other options show an improvement or positive finding. I hope you guys can look at your tests while you see this. But number 23, the answer was A, the patient's skeletal structure. While assessing a medical patient, we typically focus very little on the skeletal structure. The assessments are more important for a medical patient. I'm sorry, they're just as important for a medical patient as they are for a trauma patient. And not necessarily finding anything wrong. You can see what my son's are. You can see what the normal is. Do they have a hunched back? Do they have a barrel chest? Do they have some sort of abnormality? Some people have one leg shorter than the other. You know, if you've got polio, you also have some deformities. So, and that can also give you an indication as to what's going on. If they've got a barrel chest, you know that a lot of times that is an indication of some sort of respiratory disorder. So you can automatically be aware and be focused on that. So number 24, the pulse point behind the ankle. You can't see my ankle, but is the posterior tibial. So the answer was C. I'm trying to go faster because I feel like I'm taking forever for this. So the answer to 25 is cool. Cool skin could be a sign of shock because what do we want skin to be? Pink, warm, dry. That's normal. Anything that's not that means it's abnormal. And if it's very cool, that means that blood is not circulating there, and that's a problem. Or circulating well, not necessarily all. But so number 26 is all of the above. You should advocate and practice performing a complete and thorough assessment on all patients. That is very important. All patients, even if it seems like BS, even if you get distracted, don't get distracted. Do not get tunnel vision. Make sure to do a complete and full assessment on every patient. It may be difficult to obtain a complete assessment on the unresponsive patient due to the management of life-threatening injuries, but again, don't get tunnel vision. You're gonna get it at one point or another, and you're gonna miss it, and that's just kind of the nature of the beast with us. But I promise, if you, I'm sorry, I just went to the dentist though. If you miss something that's very important, you won't do it again. So, I mean, the goal is zero misses, zero injuries, zero problems. But if that doesn't happen, just learn from it, take it in stride, and help it to make you a better person and a better EMT, a better medic, a better fireman. You know, learn from that. I told somebody recently, and I think that this really goes with EMS very well, is that you grow through what you go through. When you see things, and you will learn, and then you can pick up on things a lot more next time. Sometimes it takes messing up to be better. I'm not saying, hey, mess up. I'm just saying you're human, to err is human. Grow through what you go through. It'll be okay. But anyways, don't get tunnel vision. Um, don't get distracted like I do. But number 27. The answer was C. After obtaining a history and primary assessment, you should obtain a baseline set of vitals after obtaining a history and performing a primary assessment. This way, if the patient does become unresponsive, you will still have been able to obtain that history. Number 28 is A. To determine skin temperature, place the back of your hand against the patient's skin. Especially with babies, because the more that you have decreased sensation, especially if you are hardworking or you touch hot things, or your nerve senses are. My daughter and her Minnie Mouse. Your nerve senses are a lot decreased, so you want to use the back of the hand. Um, number 29. The answer is D, a decreased level of consciousness. Any patient who is unresponsive should be evaluated for a head injury or significant bleeding, obviously. Um, in this case, the patient has a radial pulse, so that tells you his perfusion is still adequate and rules out shock, because if they're in shock, they're not going to have a radial pulse. They probably won't have a brachial pulse, but they'll have a carotid pulse. He may have a chest injury, but his color would be significantly altered if this were the cause of the unresponsiveness. Mechanism alone does not make the patient a high priority, but it's good to suspect. All right, y'all, we're getting there. So 30 is A, initiating CPR. CPR, obtaining an airway, controlling severe hemorrhage would be reasons to interrupt the primary assessment. And then you go right back to where you were and keep on trucking. 31. A, rolling the patient on the left lateral recumbent position. So the quickest way to reduce risk of aspiration is to immediately roll the patient on its side. But if there's any sort of injury that we suspect was spinal, we're going to hold C-spine, right? We shouldn't have to say that. I'm sure you know that. I'm still going to say it. So you can also suction, having that suction ready, but if you don't have that suction ready, even if you do, immediately turn that patient to the left side, so that way the vomit just kind of comes out and goes to the side. So number 32, for ages 1 to 10, the 50th percentile is 90 plus 2 times the years in age. So the answer will be 94. This says see page 77. I'm sure this is about blood pressure, but blood pressure defined for a child, what it should be is always 90 plus, whatever 2 times the age is in years. So 33 is the secondary assessment looks at all parts of the body from head to toe, so the answer would be B. The entire body from head to toe can be assessed. For number 34, the answer will be C, late 40s and early 50s. That's menopause, which is the cessation of menstruation, typically occurs in the late 40s and early 50s. Number 30, hold on. Okay, number 35. Flexion of the head, the neck, and the spine of a patient you suspect has a possible neck injury is contraindicated. Don't do it. Don't do it. Don't do it. Retract the lower lip with your thumb and keep the mouth open. I think I might have shown those who came to the training lab. It works well, but I typically don't like to stick my hand in patients' mouths. But retracting the lower lip of the patient with your thumb and keeping the head stabilized with the forearm is also acceptable. Number 36, the answer is B, an 8-year-old. Adolescents are between the ages of 13 and 18, and they would be expected to have the same vital signs as an adult. All patients would be expected to have a rapid pulse with anxiety in a situation such as this one. Again, I don't have the test, so it's an anxious situation, I guess. The normal rate for an 8-year-old would seem appropriate rate for the situation. The normal rate for a 2-year-old would be considered too fast for the situation. So number 37 is C, slower than normal. Sorry, I have to move around a lot. But a normal pulse rate for a young infant ranges between 100 and 160. The pulse rate may be elevated during illness such as fever. It probably will be. That's a good sign, even if you feel the baby and it doesn't necessarily feel warm on the outside because it was out in the cold, it's been naked, something. But you see a high heart rate, and the same with adults. Like fever makes, and now it's not like super high, but it's more elevated than normal. Number 38 is C. carina, the structure, which is the structure that divides the right and left bronchus. The esophagus lies behind the trachea, and the bronchioles and alveolus are the distal ends of the respiratory tract. So number 39 is Fowler's 45 degrees. Some people call it semi-Fowler's. I think that the difference is kind of like this and this. It's not really a whole lot of difference. But that would be the proper position for that patient. All right, making headway, y'all. Number 40 is jaw thrust and manual cervical spine control. As you know, when the patient has an injury, that's just when you use. Not going any further. The number 41 is to insert an NPA. I've also seen all of you do that. You've done amazing. Super proud. If I was unconscious, I would totally trust you guys to stick something in my nose. So number 42 is C. The victim will likely need suctioning prior to ventilations. And this one was about the stomas. Stomas tend to obstruct easily, and there's a buildup around that. You'll likely have to suction the opening prior to ventilating that. You can use a bag valve mask or a pocket mask. And like I said before, but I think, I'm not mistaken, only paramedics are allowed to do this, but you can put like 3 up to 10 cc's of normal saline in there to kind of break that gunk up. Weird fact, especially in the stomach, nursing homes and people who have families that have some sort of stoma, because remember, a stoma isn't just in your neck. You can have a stoma in your stomach for colostomy or for a G tube or for a J tube. So stoma is just an opening. But in the stomach, a lot of people use Coca-Cola to clean that out when it gets blocked and you can't use anymore. Kind of like when you pour Coke on a car battery and it eats the acid, which kind of scares me, but I still drink Coke every once in a while too. But Dr. Pepper's my favorite. 43 is palpation of the skull, and it's typically reserved for the trauma patient that you suspect could have a head injury, and it's least likely to be included in an examination of medical patients, but you should definitely always check lung sounds, circulatory, and pupil response, identify any abnormalities. Almost done. So So 44 is D, experiencing some paralysis of his rib muscles. Patients that have spinal cord injury that is affecting extremities could very possibly have lost nervous system control over the chest muscles. These patients should be given oxygen promptly and may need assisted ventilation. So, we're going to take a little break here for a second. See if you guys really watch this video and see if you listen to me. There was somebody on TikTok that I told you to follow, that Institute of Anatomy. I think that's their name. But they recently talked about getting the wind knocked out of you and what that is actually doing, physically speaking. So, on Saturday, if you can tell me what that's really doing, getting the wind knocked out of you, you get bonus points. Robin doesn't know yet, but I'm totally gonna do it. Okay, so, and this is not for the advanced class. They don't know because I'm just doing it for basic. But I believe in you guys that every single one of you can come up to me and tell me, or I'll just give an opportunity sometime during class. This also tests to see if you're really watching these videos. So number 47 is D, to determine how our patient's responding to treatment. That's the primary reason that we obtain or record additional vital signs for trending, to see if it's working, if it's not working, if they're stable, if they're not stable, improvement versus not improvement. Okay, 48 is look, listen, and feel. So you want to look for that chest rise, listen for sounds of breathing, and feel for the air leaving the airway. That is the initial method for assessing adequate breathing. I think we only have two more, y'all. So 49 is adolescence. Eating disorders are most common during adolescence, when children are most self-conscious and body image is of great concern. Obviously not a problem for me. Number 50 is suction machine and tubing. Suctioning a patient's airway is always a high priority. We've talked about this, just kind of beat it in your head. But all steps must be taken to ensure that you have clear airway for your patient, and that it's patent. I cannot talk today. But so that's the test. I haven't got individual results yet, but I hope that all of you did well. I know that there were some people that struggled. So if you have any questions, please call me. Like I'm here. I will even talk to you while I'm working if I can. You can call me. Just call me, text me, email me, anything. I'm here for you. You guys are doing great. Keep up the good work. I'm totally looking forward to seeing you on Saturday.